the differences in limit of detection between tests will occur. No two tests will have the same limit of detection to detect a small level of RNA. And I think that's probably what we're talking about here from review of results, is very small levels of RNA that have been detected in one test, but not been detected in another test. And that can happen, and the differences between test limit of detection are magnified at these very low levels of viral concentration. There is a certain threshold or a certain limit below which the level of virus may be considered insignificant. The other question is about samples. The swabs sent to Synlab require a swab of the back of the nose, which means going right back to the back of the nose where that meets the top of the throat. The swabs that we have been running in the public health lab have been up to date been throat swabs. So it may be that, again, if you have very low levels of virus present, that you may detect a virus at one site but not at the other. We generally don't think that's the problem when you have high levels of virus present, when you'd expect to find it in the nose, the throat, the saliva, and elsewhere in the respiratory tract. Thirdly is the issue around specificity of the test. That is, if you detect a signal in a test, is that genuinely what you're looking for? In this case, is it genuinely COVID? So overall, we're very confident that when we get a positive with our test, it is positive. We're also confident that the test that we use for screening has an appropriate threshold for a screening purpose, which is different to the threshold that would be used for a test that's used for diagnosis of COVID. And that, I think, also may explain the differences here.
And in terms of the different thresholds between diagnostic tests, is this the case between Synlab and ours? How confident are you in where the threshold is set here, and that we aren't missing any positives that we should perhaps be catching?
So the thresholds that we've adopted for our diagnostic tests, and we have more than one diagnostic test at our disposal at St Bernard's, are those that have been discussed internally and also with colleagues from Public Health England, colleagues who use similar tests in the NHS and have vast experience with use of these tests in the NHS. And we have, if anything, in the GHA, set more conservative thresholds for these tests than are used sometimes in the NHS, for instance. So I'm confident that the thresholds that we've applied, and the fact that if we do have a low level positive, we go on to run it on a different test to confirm it, are in line with good laboratory practice locally.
So a question that has been asked quite a lot: if the difference in turnaround between the diagnostic and the fast screening test is just a matter of a few hours, couldn't it be argued that it's better to have a more accurate picture to prevent the spread of the virus in the community?
Yeah, I think there's a kind of a sweet spot to be found between test sensitivity, specificity, and turnaround time for screening. Yes, you could use an ultra-sensitive test that picks up every last scrap of RNA and takes 4 or 5 hours, but that will have a knock-on consequence in those individuals who are most infectious, still wandering around in the community and spreading virus when actually you want to identify those as quickly as you can in order to ask those individuals to quarantine and also identify their contacts and quarantine their contacts. So for a screening program, turnaround time is highly important. I'm not saying that sensitivity isn't, it is, but it's an acceptable level of sensitivity. We know our LAMP test has an excellent performance in detecting those that are high-level shedders, well above 90%. We're talking well over 99% in detecting those who carry a high level of virus in their upper airways, and that is what we need.
And aside from the question of testing, how important is it to adhere to public health advice on the matter of social distancing, hygiene, masks, and so on?
The single most important intervention that we have identified to control the spread of COVID is actually social distancing and adherence to public health measures. I cannot emphasize the importance of that enough as the means that we currently have available at our disposal to control the spread of COVID within a community.